Guys, this is Mobeen. We are talking about the respiratory system pathology. The diseases that we are covering are restrictive lung diseases, and within that we are discussing sarcoidosis. Now, sarcoidosis is not a disease of the pulmonary system only. However, in 90% of the patients of the sarcoidosis, when the disease becomes progressive enough to cause issues, then the 90% of the cases, lungs are involved. And when the lungs are involved, in 10 to 15% of the cases, severe interstitial fibrosis occurs, which causes restrictive lung diseases. That is why we are discussing sarcoidosis over here. Now, the definition of sarcoidosis is, it is non-caseating granulomatous disease of unknown etiology involving multiple systems. So now there are a couple of things that you have to be careful about. If you receive a patient that has fever, weight loss, fatigue, lymphadenopathies, and you do some biopsies for the lymph, and you find in the nodes or in other parts of the body, and you find granulomas, non-caseating granulomas, you should not be quick to say this patient has sarcoidosis. So sarcoidosis diagnosis is of exclusion. What does that mean? What that means is you rule out other reasons of non-caseating granulomas. For example, tuberculosis, Mycobacterium tuberculosis can cause non-caseating granulomas. Fungi can cause non-caseating granulomas. Certain viruses and certain other such things can cause non-caseating granulomas. Borrelia can cause non-caseating granulomas. Borreliosis can cause non-caseating granulomas. So for all of those, you have to rule them out before you say this is sarcoidosis. Now, with that in mind, let's start with the pathogenesis of the sarcoidosis. Again, we do not know the etiology, but we think that there are three basic problems for causing or precipitating sarcoidosis. There is a genetic predisposition in which HLA-A1, HLA-B8 is prevalent, or the patients or the persons with those genetic makeups. Then African Americans have 10 times more incidence of sarcoidosis in America. Women have more incidence and prevalence than men. Interestingly, patients who are under 40 years of age, so young patients, and non-smokers. So this is probably one of the very, very rare diseases that are for non-smokers. So to prevent it, start smoking. No, don't do that. So that is the genetic predisposition. On the immune disorder, the CD4 cells are supposed to be dysregulated in this particular situation. Now, what do? We'll talk about it in a second. However, there is CD4 cell dysregulation. So there is some problem with the immune system, and then there is some antigen of unknown origin. We think it may be some pollens, Borrelia, some viruses, and Mycobacterium tuberculosis, but nothing is certain. So with this, let's talk about what is the mechanism of production of non-caseating granuloma. So what happens is this. So let's say this is the antigen, the ninja antigen, that we do not know what is the origin of it. Maybe one of these or maybe something else. However, when this antigen comes into the body, of course you know macrophages and neutrophils will pick it up, and they will present parts of this on their surface, right? Normal innate arm of the immune system. Macrophages will now run with this antigen and go to the lymph nodes. So with the sarcoidosis, keep in mind the lymph nodes that are hilar and paratracheal lymph nodes. So macrophage is going to go and run there and say to the cells, which cells there? T cells and B cells sitting in those lymph nodes, and say, dude, I got this antigen. So the CD4 cell that is sitting here, so let's say this is a CD4 cell. CD4 cell will be presented with the antigen, and what would happen is it would start releasing IL-2. CD4 cell, when it would release IL-2, this IL-2 is going to cause proliferation of the CD4 cells. So we'll have monoclonal proliferation of CD4 cells. At the same time, CD4 cell is also going to release interferon gamma. Interferon gamma. That will activate the macrophages. Now this is the line that would cause granuloma formation. So this is the mechanism: antigen, presentation to the cells, CD4, proliferation of the CD4 cell, amplification of inflammation, activation of the macrophages, formation of large and active macrophages, which when there is continuous activation, then these macrophages will become fused and become, so now I'm going to fuse them, so they'll become multinucleated giant cells, multinucleated, many nuclei, because this is a fusion of many cells, multinucleated giant cells. Now how does this happen? When a macrophage becomes active, that macrophage in turn is going to release IL-8, tumor necrosis factor 2, and then macrophage inflammatory protein 1 alpha. All of these proteins not only cause inflammation, but they would also cause recruitment of more macrophages, monocytes and lymphocytes. So monocytes will also come in. So further recruitment and inflammation would occur. This would cause amplification of all of these cytokines. These cytokines would also act on the macrophages, and now the macrophage will convert into two types of cells. One is the multinucleated giant cell and the other is epithelioid cells. So what are epithelioid cells? Epithelioid cells. Cells, oid mean look like. So cells that look like epithelial cells. What does that mean? These are actually macrophages that have become hyperactive. They are usually long elongated cells. They are pink in the cytoplasm is pink, and they look like epithelial cells. However, they are irregular in their shape. So in these granulomas, what you will find is, you'll find lots of epithelioid cells. You'll find lots of giant cells, right? And then the granuloma itself, now this has become granuloma. It takes time to become granuloma. The granuloma is bordered or rimmed by, there is a rim of CD4 cells or lymphocytes around the granuloma. So this is the structure of this granuloma. Inside the granuloma, there are two types of bodies or depositions that are important to understand from Steph's point of view and from general histopathological point of view. One is that there is, so if I make one big cell over here, let's say this is the macrophage or a giant cell that is coming from here. I just brought it here. This cell has gotten, so let's say this is the nucleus. This cell could have concentric depositions inside the cytoplasm, deposition of calcium and proteins. So this is the Schaumann, Schaumann, Schaumann bodies are found, and it is also possible that there are deposition of the substances that look like a star. So asteroid bodies. IES, asteroid bodies. So Schaumann bodies are found, asteroid bodies are found. At the same time, imagine with this pathogenesis, with this mechanism, what will happen to the CD4 cells? So the CD4 cells are consumed, and due to that there will be energy, ANERGY, energy to PPD and candida like skin tests. So what does that mean? You do the allergic test, and ideally if the patient is allergic to something like PPD or candida, there should be a wheal and flare and a small induration that should form. However, because the immune cells are all consumed up taking care of this mechanism, there are not enough immune cells to go and do that induration formation or the local inflammation reaction, so the patient does not react to these antigens. So that is a very important thing to keep in mind. If you take the chest x-ray of these patients, what you would see is that their hilar and paratracheal lymph nodes, they are big like potato lymph nodes. So there is lymphadenopathy and large lymph nodes are found. Now, a couple of more interesting things. Number one, in these patients, the angiotensin converting enzyme, some of them, about 5%, the ACE enzyme is increased. Why is it increased? It is a non-specific finding, but this is a finding. At the same time, there is hypercalcemia. Can you tell me why hypercalcemia? Look at this all and tell me why would we have hypercalcemia? So what happens is that these giant cells, these epithelioid cells, these active macrophages, they create alpha-1 hydroxylase. So alpha-1 hydroxylase is increased. When that is increased, of course, that means vitamin D will be increased. When vitamin D is increased, that means calcium phosphate metabolism would become hyper, and that would increase the calcium levels. So this is how, and that means that it is not necessary that only hypercalcemia occurs in sarcoidosis. Any disease where there is the giant cell formation and there is granuloma formation, this can happen. Cool. So now let's talk about what are the pathologies that occur due to the granulomas that form throughout the body. To save your time, I drew it when the cameras were off. So here is a human being, and let's look at the sarcoidosis from head to toe, what kind of involvement and what kind of diseases can be part of the sarcoidosis. Now remember, it's not necessary that all of these would appear at the same time. There are various ratios, and sometimes you don't even know that the patient has sarcoidosis. Patient doesn't know that the patient has sarcoidosis, and they come in for some regular exam or something, and you discover that there is sarcoidosis going on as well. So let's see, let's start from the head. So scalp can be involved, there can be skin lesions. On the nose, lips and cheeks area, lupus peyronie can happen, which are violaceous rashes, which are raised rashes. So violet colored rashes of the skin near the nose, cheek and the lips, that can happen. There can be lesions on the face, scalp and neck. There can be lesions on the back of the patient, skin lesions. There can be lesions on the front of the legs, but these lesions are different from these. These are painful inflamed lesions. This is really the fatty inflammation called the erythema nodosum. Painful fatty inflammations of the front of the legs. But if there are indurations present on the back of the hands and arms and back and the face, normally these are less painful or not painful at all. With that, we're going from down here. Brain meningitis can occur, and pituitary gland can be involved, which can result in diabetes insipidus. That can happen. As we continue to come down here in the facial area, parotid gland, bilateral paroditis can occur, so parotid gland can be involved. Eye here, so of course with the parotid gland, so if I back up for a second, parotid gland involvement would cause xerostomia or dry mouth, right, dry tongue. How about eye? So uveitis would occur, so I'm going to make the eye on this side, so here is the eye. So there could be, if this was the eye, the uveitis of the, or iritis of the interior part or posterior part, or both can happen. So if there is iriditis of the interior part or iridocyclitis of the anterior part, then what would happen is opacities on the cornea can appear, and if there is involvement of the posterior uvea, then the retinal damage and optic nerve damage can happen. So these are the eye changes. With that, lacrimal gland can be inflamed, and when the lacrimal gland is inflamed, there are going to be no tears. So no tears. So if these are tears, there will be no tears. So that is called Zika syndrome. So Zika syndrome may be present, xerostomia may be present. Then as you continue to come down here, inside the chest, the heart, there can be pericarditis. Of course, the most common 90% of the cases, we will have huge hilar lymph nodes, and so hilar lymphadenopathy will be there with the potato hilar lymph nodes. Then paratracheal lymph nodes may be enlarged. As you continue coming down, so this is the most important area, the lungs area. 90% of the patient would have that. So this is the most important for the sarcoidosis. That is why we are studying it here. When this becomes bad, when this becomes progressive, in 10 to 15% of the patients, near the lymphatics. Why near the lymphatics? Come here. This whole system, macrophage is going to the lymph nodes, and then CD4 cells and B cells coming back from the lymph nodes. All of them are going to be causing inflammations around the lymphatics, which also tells me here, I did not talk about IL-4 and IL-5 secretion, which will cause B cell activation, which will cause polyclonal antibodies. So monoclonal CD4 cells, so one CD4 cell type becomes proliferated. However, antibodies of various forms, all B cells become active and polyclonal B cell antibodies are formed. So that is also dysregulation. So back here, around the lymphatic channels is the inflammation and interstitial fibrosis occur. So that is what would happen in the chest area. If you come down here, it is possible that you would see liver enlargement because of granulomas in the liver. You would see spleen enlargement because of granulomas in the spleen. As you continue to go down, you would see the problems with the bone marrow. Bone marrow involvement can occur, and the erythema nodosum on the lower legs can occur. So let's quickly talk about the clinical and the treatment of the sarcoidosis. Clinically, the patient would come to you, maybe sometimes they don't even know that they have sarcoidosis. Sometimes they'll come to you with the fever, cough, weight loss. It is really the chest x-rays that would make you suspicious, and then you'll take the biopsies, and from there you'll work your way up to find out if there are granulomas. If there are granulomas, then you would have to figure out other diseases that can cause granulomas to then settle on the sarcoidosis, which will be unknown reason of non-caseating granulomas. So that is the clinical. About 10 to 15% of the patients will develop the progressive interstitial fibrosis, which will then cause death because of the respiratory failure and cor pulmonale. In majority of the patients, 70-80% of the patient, within 2 to 3 years, this disease automatically resolves and goes away, and so nothing happens. Now, treatment, ideally it should automatically resolve, but if not, the steroids is a treatment of choice. Another treatment that is tried is the tumor necrosis factor. So see here, tumor necrosis factor here. So tumor necrosis, TNF blockers, tumor necrosis factor blockers are also used to reduce inflammation and slow down the progress of this disease. Thank you very much.